Prof Ahmed, Elsheikhah, Professor of Obstetrics and Gynecology, Fetal Medicine Unit, Cairo.
Thank you very much for the invitation. And it's actually quite difficult to talk about such a wonderful speaker. And I'm actually going to talk about our teamwork at Fetal Medicine at Cairo University. We've been looking after quite a few cases of in vitro anemia, so that approach will be a bit different now. And we've been doing quite a few cases of intertransplant transfusion and actually achieving the good results with new advances in our neonatal unit. I have to be grateful for that because they really managed to look after really sick babies and they also got well. I'm going to address a few issues in the lecture. I'm going to talk about the causes causing in vitro anemia, the importance of the early diagnosis, and the lines we use for our diagnosis, the lines we use for our treatment, and how do we follow them up in future pregnancies. And we have to actually elaborate a lot on the fact that early diagnosis is the main key. We do not want to start treating those patients when the babies are already hydropic. We know that the survival is nearly zero in those cases. So the main causes from our perspective are mainly hemolysis, and that's our commonest one, preterm hemorrhage, congenital infection, and some other rare causes affecting the bone marrow or affecting the red cell membrane, which I'm going to touch briefly on in a slide. If we look at the commonest cause of stage, which is the hemolytic cause, which is the hemolytic cause of anemia, caused mainly by maternal antibodies in cases who are Rh negative who have been sensitized during pregnancy. But it's not only Rh disease. We see quite a lot of anti-cal, and anti-cal can sometimes be as aggressive as, or even more aggressive than Rh disease, and I've seen quite a few cases of those. And some of them as well, we see a mixture or a combination of more than one type of antibodies in a single patient. Right? Perhaps the patient was sensitized for Rh, but the baby was Rh negative, but she was as well sensitized for cal, and she had antibodies that proved immune to cal in that pregnancy. Those are the ones which actually we treat. Those are the ones when we start intertransplant transfusion, we can change their outcome. The non-immune causes are not treatable from our perspective because we cannot really help them. We treat the immune ones because if we correct the anemia while they're pregnant, then the baby will survive, hopefully, with good neonatal care, and then they will have a normal outcome. But the ones who are non-immune, which are thalassemia or genetic causes causing red cell enzyme defects or membrane defects, are obviously not treatable at that stage. The hemorrhagic causes are actually quite rare. They are usually an accident sort of thing, like placental separation causing fetal-maternal hemorrhage or the spontaneous fetal-maternal hemorrhage. They're actually quite rare, and usually those fetuses hardly survive. And the other one that we're interested in is congenital infections, particularly parvovirus B19, because there are two important viruses causing anemia, parvovirus and cytomegalovirus. But cytomegalovirus, from our perspective, if it affects the baby severely, usually the baby will have serious damage and will have a very poor outcome. But the parvovirus B19 will cause temporary anemia due to suppression of bone marrow, and as well due to cardiac inhibition. And if we catch them and transfuse them, even if they're hydropic, and those are the only ones, if we transfuse them while they're hydropic, they will have a totally normal outcome with a very, very high successful outcome. The pathophysiology causing the fetal anemia and the changes that we use for our diagnosis is mainly due to the antibodies, which are usually of the IgG class, crossing the placenta and attaching themselves to the fetal red cells, and they are usually destroyed by the fetal immune system quite quicker than what they're used to. And in mild to moderate diseases, there is compensatory increase in the medullary erythropoiesis, and in severe cases as well, recruitment of extramedullary sites like liver and spleen. If we all remember that the fetal hemoglobin level is about 18 grams per deciliter at that stage, and obviously all fetal hemoglobin, the baby will be able to maintain the pressure of oxygen, carbon dioxide, the pH, usually until they reach a very severe disease or a very severe stage. And they try to compensate by increasing the 2,3-diphosphorylated levels in the red cells, to try and release more oxygen since this is fetal hemoglobin, not fetal hemoglobin. And when they reach a really high stage of anemia with hemoglobin levels below 5 and 6 grams per cent, that's when they would not really reach the capacity of lactate clearance and would have low oxygen levels. It's the cutoff of this hemoglobin level going below the 5 or 6 grams per cent. So that causes the fetal hydrops, and actually the hydrops has got lots of theories. Some of it is the increased infiltration of the liver or excessive infiltration by erythropoietic tissue, leading to portal hypertension and hyperproteinemia due to impaired protein synthesis, secondly due to hypoxia and hypoxemia they face. That's what we try and tell our physicians, and we don't really want to reach that stage. We don't want to reach the stage where fetus will have skin edema, cardiomegaly, bilateral pleural effusion, and ascites. You don't really want to reach that stage. You want to see those patients earlier than that, because if we reach that stage and we even do the most aggressive type of treatment and we give them inter-time transfusion, still the survival is under 20%. And our experience is we haven't had any survivors with severe cases of fetal hydrops in utero. But if we see them and we treat them before they reach that stage of fetal hydrops, and I'm going to explain why that's so important, we have a successful survival rate exceeding 70 to 80%. So, the fetal anemia is associated with increased arterial and venous blood flow velocities, and this is mainly due to the decreased blood viscosity, with a consequent increase in the cardiac output, because you've reduced the red cell mass in relation to the total blood volume. So obviously you have less viscous blood, so the blood flows much quicker, and this is actually the sign that we use to diagnose that those fetuses are anemic. And this observation can be easily seen by ultrasound, and we choose a certain vessel to check for that, and this vessel is the metacerebral artery in the fetal brain. We have our own protocol in the unit right now, which is actually an agreed protocol. We follow those patients based on multiple lines. First of all, it's the history, whether they have had a previously affected pregnancy, in the sense whether they have had previous fetal loss due to hydrops, or whether they have had previous very early onset neonatal jaundice at day 1 following birth. And as well, we monitor the level of maternal hemolytic antibodies. We observe the changes in the fetal blood flow velocities mainly at around 18-19 weeks, because we can start transfusion at that stage. We look for other altered changes in the fetal body as cardiomegaly, and obviously if we leave them, they will reach fetal hydrops. As well, there is some morphometric changes that happen in the placenta by increased placental volume due to placental edema, and at late stages they will reach pathological fetal heart rate patterns probably when they are terminal. The main confirmation of fetal anemia, unfortunately, is by doing cholecystitis when we puncture the fetal cord and take a fetal blood sample, but we obviously try to avoid doing that excessively, because we know that the fetal loss rate just by puncturing the cord is around 5 to 10%. So we try to be as selective as possible, and when we do reach the stage when we're doing cholecystitis, we're doing two procedures at the same time. We'll take a sample first of all to confirm, we do the transfusion at the same setting, and we take another sample post-transfusion, which I'm going to explain now, confirm that we have actually managed to correct anemia to a reasonable level. And as I say again, the main aim is to try and predict and treat fetal anemia before fetal hydrops develops. And because, as I say, if we reach hydrops, the survival is very good. If we look at the outline, we go with the history. We start by the maternal antibodies in our previously affected pregnancy. So if we have a previous pregnancy, we check always with the enlarged Coombs test, and we know the cutoff is about 1/128, or about 15 international units. We look for other important issues in the history, like exposure to infections, particularly parvovirus, or history of bleeding in pregnancy. And if we focus again on the level of antibodies, because I get a lot of referrals from the unit where women would get recurrent fetal hydrops, but they are not sensitized. They are not due to immune causes, and if they are not sensitized, then by all means they do not respond to treatment, because it carries usually a genetic cause, and this is not a treatable cause at that stage. We look for the maternal serum antibodies and the Rh state of the mother, and as well we look for other antibodies like anti-Kel and Duffy and sometimes stability. We can check for the fetal cells in the maternal blood, and this can diagnose the fetal Rh status. We can actually check that by looking for fetal DNA and RNA at around 11 to 13 weeks. The test has been quite elaborate and reliable, and it's available actually for under the NHS in the UK. We hope to have it soon in Egypt at the moment. We look for serology for congenital infections, but the issue about congenital infections, they are usually not recurrent, and they will not cause severe disease. So even if you have a CMV infection, I'm not expecting a woman who will have a recurrent infection with CMV to develop severe fetal anemia. And as well, the most important one for us is the indirect Coombs test to check for the presence of maternal antibodies. And then we come to the value of the ultrasound, where we look for changes in the fetus. So we look for the speed of blood flow in the fetal brain to try and diagnose those fetuses early. And this is how we look for the middle artery. It's quite an obvious vessel in the middle part of the brain. We try to take the upper 1/3 of the vessel to avoid the lysing of the circle of Willis. We have obviously a criteria on how to use the test. So we have to correct the angle, we have to avoid pressure on the external abdomen. There is certain criteria which has got a very small or a very short learning curve to appreciate that. And we look mainly for velocity. We're not looking for resistance or pulsatility index. We're looking mainly for increased velocity above a certain level. And this is an interesting case. You can see here the velocity was actually quite good, and a week later the velocity was rising, so the mother was developing, the fetus was developing fetal anemia to help guide us into the transfusion. There's lots of vessels, but the middle cerebral artery is the most interesting of those, and we have cutoffs which are related to gestational age. So let's say the woman is 25 weeks pregnant, so we know that the cutoff would be around, let's say, 38 centimeters per second. If we exceed the 1.5 standard deviation, we know that this fetus is anemic. We start the procedure of transfusion at that stage and not wait for fetal height, and that's the main aim of the test and the main target. And we know that there is a very good inverse relationship between the fetal hemoglobin level and the middle cerebral artery peak systolic velocity, and the test is actually quite reliable, and we haven't had any false positive cases in our series. So how we do the transfusion is actually a procedure that can be done either intraperitoneal before 20 weeks, but the success of intraperitoneal transfusion is actually quite poor due to a couple of factors. The fetus will not usually develop anemia due to the recognition of the antibodies before 16. So if the mother is actually developing hydrox at 18 weeks, then the disease is so severe that it will not even give us the luxury of being able to do repeated transfusion, because it will damage the cells that the fetus has in the circulation a lot quicker. But the aim is to actually transfuse the blood directly into the fetal veins by doing photosynthesis, and that's when the earliest time we can do that is after 20 weeks. We can't do that before that, because if we puncture the cord before 20 weeks, then we end up cutting the cord, and the cord will be lost. What we look for is we look for the type of cord insertion, and we look for the cord insertion mainly because that's the area where the cord is fixed, so it will not move if you touch it. And as well, we have to prepare blood which has got certain criteria, because we cannot do exchange transfusion similar to what we do neonatally. We only do a top-up transfusion. So we have to get a limited volume of blood, otherwise the fetus will be already anemic, and we give them a high volume of blood, so we'll obviously get them into a high degree of congestive heart failure. So we choose a volume of blood that is related to the gestational age, like at 20 weeks we only transfuse about 10 mils, 21 it's about 15, and we have tables to elaborate on that. The blood has to be ORH negative, it has to be highly concentrated with hematocrit exceeding 8 to 90 grams per cent. It has to be washed and filtered to reduce the transmission of antigens that can cause allergic reactions, and it has to be irradiated to reduce the transmission of CMV and other viruses. We actually aim for the vein. We know the cord has got 2 arteries and a vein. We aim for the vein because the caliber of the vein is wider, and because if we puncture the artery, then we end up causing transient bradycardia, which can actually go into cardiac arrest and ischemia. So I know how tough it is. And it's actually technically different when we have an anterior placenta like this situation here, because the cord insertion is just in front of the entrance of the needle, and you can actually easily cannulate the needle similar to cannulating another. It's actually quite an interesting procedure to do when the placenta is anterior, very easy and straightforward. Although when we do other procedures in the fetus, we do not like to go transplacental, but that's the only procedure when we go transplacental. Because getting the needle transplacental can cause or can increase the risk of placental separation. You can see here is the vein and here is the artery on top of it. We'll take a sample first of all for pre-transfusion hemoglobin to understand where we write in our diagnosis, and as well before we start the transfusion, so that we can do serology. We want to do indirect forms on that. We want to check the fetal RH status. So we check 3 things before we start the procedure for the transfusion itself. We'll do the transfusion, and at the end we'll give about 1 to 2 minutes of saline and wait for about 2 minutes, and then take post-transfusion sample where the blood has flowed evenly into circulation to see whether we have managed to correct the anemia properly. The difficult one is the posterior placenta, because we have to go transamniotic, as you can see here. We have to hit the cord insertion at the right angle, and the baby is moving, and you can get loops of cord on your way in, so it's actually technically more difficult to do. And as well, we have one final goal, which is doing it intracardiac, and this is actually quite a tough one to do, because we only do it when the fetus is actually quite bradycardic due to high vagal tone when we try to puncture the cord, or if it's bleeding from the cord side. So we have to go intracardiac. It's actually quite technical, and not only technical, we're doing it on a bradycardic fetus, which is even more difficult. And as well, they usually thrombocytopenic as well. They're not only anemic, so we have to actually evacuate the pericardial space while we're taking the needle out, so we don't develop hemopericardium while doing the procedure. It's actually quite a tough one to do. So what happens following the transfusion? There is a significant decrease in the peak systolic velocity, which is noted within a few days after the transfusion, and this significant decrease is caused by the correction of fetal anemia for sure, and as well a little bit of congestive heart failure, which can occur due to overloading of the fetal circulation, and as well as cardio inhibition action due to the increased blood receptor activity, secondary to the better development or better delivery of oxygen levels to the periphery of the tissue. We have actually had quite a few cases of transfusion over the last couple of years. We used to suffer in the first year because we used to have very successful outcome from our perspective, the gynecology or obstetrician side, with post-transfusion hemoglobin reaching about 10 grams. And the issue we understand is that after doing the procedure carries the risk of increasing the chance of spontaneous prematurity. So some of those women would be delivering at 32 weeks because of premature contractions. They would last with us for 3 or 4 days in the unit upstairs, and they would not survive. But currently, the unit has been actually doing quite an excellent job, and I'm actually quite grateful for them. We had maybe about 6 cases over the last 3 months, transfused them repeatedly. They all survived. The youngest was about 31 weeks, and with a weight of about 1.8 kilos. But we had no survivors with no improvement in the outcome at all with the ones who have had fetal hypox, because we know that at that stage the pre-transfusion hemoglobin is about 2 grams, and when we transfuse them, we can only reach under 5 grams, because as I say, it's a top-up transfusion and not an exchange, so they never get a significant improvement in their cases. And that's why we counsel them, and we talk to them about the procedure clearly before we do it, and we try to elaborate, and we try to actually encourage physicians to refer the patients early as much as possible, for us at around 16, 17 weeks, so that we can plan and start the transfusion even at 20 weeks, although technical, although difficult, although time consuming, but the outcome is excellent when we start at that stage before fetal hypox. And what do we do with them in future pregnancies? Immune cases will be brought up down the same lines. We actually had quite an interesting case, which I would like just to mention. We had a case who had fetal hypox in the previous twice, with 2 fetal losses, and then she was referred to us. She's Rh negative, definitely sensitized with the titer antibodies of about 1,052. As well, we followed her up. She did not develop anemia, and then she suddenly showed anemia at around 28, 29 weeks, which was actually quite late for us to develop that onset. And at that stage, we said, well, if there's something wrong happening here, we started the first procedure of transfusion, and with the sample of the fetal blood, the baby came back as the baby was Rh negative, and that's why we developed the anemia late. But the baby had a CAL, and the mother had anti-CAL antibodies as well, so she had a combination of CAL and Rh disease, and that's why she developed the anemia late. This baby was delivered at 33 weeks with a weight of about 2.2 kilos, and actually survived very well after three sets of intra-transplant transfusion. Congenital infections for us are actually not an important issue because they're not really recurrent, and they do not cause severe anemia in future pregnancies. So if the baby has been damaged by CMV infection, usually recurrent CMV will not cause that type of anemia. And as well, parvovirus usually have reasonably solid immunity. Fecal maternal hemorrhage is a non-recurrent cause, and genetic testing for patients who are carriers for hemorrhagosis, obviously, that's the main theme of this meeting. So what we tell those patients is, please come back and see us in future pregnancies, even if they have successful outcome. Come and see us early. We scan them in the first trimester so that we date the pregnancy properly. We start seeing them at around 16 weeks. We start transfusion once the fetus shows features of anemia by rising in the metacellular artery systolic velocity and not by hypox, because if we wait for hypox, it's too late. We will be attempting the procedure of transfusion after good counseling of the outcome and all of that. And hopefully, we hope for the best with such procedures, particularly with the good backup from the hematology side. And I have to elaborate again, we actually counsel them very carefully. If they have siblings, then I would actually strongly discourage them from getting pregnant. I know the other way around, they don't do that. But if they are adamant of having another pregnancy and they're going to go through all the procedure, and I keep telling them we have a fetal loss rate of about 10% per set of transfusion. We're going to be doing it at least 6 or 7 times during the pregnancy. We're starting that at 20 weeks. We have to wait for the blood. We have to have an interfere. Some of them are actually quite adamant of having another child, but if we have one, then actually that's a blessing. The problem I face, and I faced it more than once, women who have accidents as children, who have been transfused incorrectly, who have been sensitized, and they have a very aggressive disease. They come with hypox before 20 weeks. They don't have any surviving children. Try transfusion, no improvement in the outcome whatsoever after 3 or 4 times in the transfusion. Although we correct the anemia after doing the transfusion repeatedly, he obviously changed quite a bit some of the fetal circulation, so he does not have the Rh positive red cells as he has, because we've already given the other hemoglobin which lasts longer in the circulation. But despite that, because they have been exposed to hypoxemia for quite a significant period of time, they do not actually get significant improvement in their height. And that's when it becomes quite technical or quite actually difficult to do. Again, I thank all the Unimeter team. It's been a teamwork which has been wonderful over the last couple of years. It's been very challenging. They've been very supportive and they've been very helpful. And I thank you for thinking.
Thank you very much, Professor Ahmed. Elsheikhah, would it ask you a question for my own interests? You said that you can give blood transfusion, or somebody can, intraperitoneally. How is it done? Not by cold.
No, usually they have a bit of ascites, because we don't do intraperitoneal transfusion unless they are actually showing severe features of anemia before 20 weeks. So you usually have a rim of ascites, and if they have a rim of ascites, you can actually go into the empty space where there is the acidic fluid is. And that stage we transfuse about maybe 10 to 15 mils of the same quality of blood, but the outcome is not good because they usually have very severe disease which will actually damage all the blood that you transfuse quite quickly. And if they're developing heart attacks at that stage, as you can propose,
is how the blood will go to the circulation.
We don't really know, but we know that they can absorb quite a bit of the blood, or maybe this can help actually correct the ascites by improving the viscosity of the ascites, similar to what we do with other cases of hypoproteinemia. So he absorbs a little bit of the protein, and this helps correct the hypoproteinemia they have. And until we reach 20 weeks, that we can do the proper intravenous transfer.
Thank you. Any other questions for Professor Ahmed?
Thank you very, very much. This is very interesting lecture. Actually, I would like to ask you if there is any characteristic findings, fetal findings, in the immune reaction, apart from ABO, KEL, DAF, or for example, lupus, erythematosis, or other immunological mother disease, how can it present in the fetus as an immunological disease?
Well, famous, the systemic lupus is causing heart block, complete heart block. We see that. And I've actually seen a couple of cases where were actually quite interesting. I had a mother who was RH sensitized, referred to us before with high troops, obviously late presentation. We tried intracranial transfusion, did not work. She delivered at 29 weeks, obviously with no survival. Second pregnancy, she did not show any features of anemia at all throughout the whole pregnancy, and this was interesting. So we thought this baby is probably RH negative, and the father was heterozygous. So we thought the baby is RH negative, she's probably going to have a normal outcome. At about 25 weeks, she developed repeated ectopic heartbeats, although the fetal echo was perfectly normal. And we, at about 34 weeks, 33 weeks, she said there's reduction in fetal movements. We checked her, she showed features of anemia. We decided to terminate at the second day. The fetus was born with hemoglobin of 5, although the fetus was RH negative, and did not survive, although they started inotropes straight away. I guess there's always a point when there's other factors that are not always elaborate, there are other factors that we will not always see, and we try not to be tempted by the fact that we would reach the 36, 37 weeks mark in those patients. We always know the antibodies are there, they can cause other issues, they have mixture of antibodies, it's not always the RH, and I guess we were tempted that the baby did not show features of anemia, so we did not have grounds to tell us we should terminate at 32, 33 weeks like we did with the others. But unfortunately, this was one of the losses we had, and I guess we learned the lesson from that.
Thank you very much. Is there any question? Thank you very much. Thank you for all the speakers for very interesting session, and thank you all for attendance. We will start immediately.